Good morning, everybody. So I am here from the University of Florida. I do a lot of imaging there, and so I'm going to talk to you a little bit about the appropriate use of cardiovascular imaging in asymptomatic patients in screening, and want to thank Astellas Pharmaceuticals for their support of having me here. I have nothing financial to disclose other than the fact that I am an imager. And I'm actually going to go ahead and give you the preview of the rest of the talk, which is that despite being an imager, you would think I would be here to tell you to do a lot of imaging, and I'm really not. So in asymptomatic patients where you're looking to screen for coronary disease, there's really not good evidence in general for cardiovascular imaging. And so we're going to go through that this morning. Our learning objectives are here. We're going to talk a little bit about risk factors for coronary disease. We'll go over strengths and limitations of imaging modalities in terms of how well they perform in this population. We're going to go over mechanisms of action of the pharmacological agents that are available for stress testing, and then wrap all of this up by integrating these facts into the clinical guidelines and the appropriate use criteria. So we have to start off with the obligatory slide about risk factors with coronary disease. We've obviously been talking about this for a while at this meeting. Smoking, high blood pressure, cholesterol. Why are these important? And they're important because if we can reduce risk factors, we can reduce events. So I've given you just two graphs on this one slide here. On the left-hand side of your screen, you'll see data from the Nurses' Health Study. Thousands of women that were followed for 15 years and looked to see if you were able to adequately control cardiovascular risk factors, how much could you reduce events? And it's really a substantial division here. So in patients that were able to, in subjects that were able to achieve all optimal cardiovascular health metrics, their risk of mortality over 15 years was under 10%. In contrast with those who could not achieve any optimal cardiovascular risk factors, and their mortality was over 30%. So an over threefold absolute risk difference in cardiovascular mortality if we can reduce these risk factors. In contrast, on the right-hand side of the screen, you'll see one of the slides from the COURAGE trial, and this was a pivotal trial looking at percutaneous coronary intervention, stenting, versus medical therapy in patients with obstructive coronary disease. So despite obstructive lesions, stenting was not able to reduce death or MI. So prevention works, and for stable coronary disease, stenting doesn't seem to have much of an effect. So that's why we're interested in risk factors, right? So when we take a look at cardiovascular disease guidelines, there are hundreds and hundreds of pages that talk about cardiovascular risk assessment and disease prevention in asymptomatic adults. We've got American guidelines, we've got European guidelines, and these are just the ones, these four here are just the ones that I selected for this talk, but there are other specialty societies that have put things out as well. Within those, there are a number of guideline recommendations specific to imaging, and I've got slides in here to summarize all of those individual points from the guidelines. But if you're looking for recommendations about imaging, you really only need to look at the most recent document that we put out, the appropriate use criteria for stable ischemic heart disease. And those cover all of the recommendations, and they basically mirror what are in the guidelines. So that's what we're going to focus on when we talk through the slides. ACC guidelines work like this. So a Class 1 recommendation is something you should do. A Class 3 recommendation is something you should not do. Class 2 recommendations are things that are either reasonable or may be considered. Each one of our recommendations comes with a level of evidence. So a level of evidence A means that there are multiple randomized trials, there are meta-analyses, there's a clear, strong evidence base. None of the recommendations I'm going to provide for you today on imaging have level of A evidence. Most are expert opinion. Some have some cohort studies or single trials. We define cardiovascular disease risk in this fashion, which I think everybody is probably familiar with, but you use whatever risk estimator you want to use, Framingham, the ASCVD risk estimator, the European score system. And if you have less than a 10% risk of cardiovascular events at 10 years, we consider that low. If it's 20% or higher, we consider that high. And anything in between is intermediate. So, appropriate use criteria. How many people in the room are familiar with these, have used them, have heard of them? Okay, so we've got some room to learn here. So, appropriate use criteria they're a little bit different from guidelines. They are a structured way that a professional society or a provider group can try and go through a series of reasons, clinical indications, why one might do a test or do a procedure, and rate different options for how to manage that condition. So, we'll take the imaging ones here. So somebody who has low cardiovascular disease risk, they are asymptomatic. That's a clinical indication. That's a clinical scenario. And then appropriate use criteria can be developed where a group of experts will sit in a room and say, how many people think that doing treadmill testing is good for that patient? You know, and they vote. And then some same group says, how many people think that we should do stress nuclear for asymptomatic low-risk patients, and so they vote. It's more structured than this. It's more formal, but that's basically the idea. And so they are intended to try and put some structure to the development of recommendations for individual tests and procedures. The way the recommendations then come out are one of three categories: appropriate, maybe appropriate, or rarely appropriate. Where appropriate, I've got the definition for you here, but the basic idea is that an appropriate test is one where the expected information you're going to get from that test is substantially in excess of the potential negative consequences, such that the procedure is considered acceptable care. So you're going to get some additional diagnostic information. The downside of that is the time, the cost, the risk to the patient, false positives, false negatives, all those sorts of things. So we're going to balance each of those things and decide how appropriate do we think it is. All right? So we've developed those for imaging, for stenting, for valve procedures. We've developed them for all sorts of different things within cardiology. But they're also appropriateness criteria from radiology and other professional societies out there for a variety of different sorts of things. I want to take one moment to talk about cardiovascular disease in women, because I hope everybody here knows that cardiovascular disease is the #1 killer of women and men in the United States. And there are some sex-specific risk factors, such as preeclampsia, gestational diabetes. There are clearly disparities in care where women do not receive the same screening or the same treatment as men. But when it comes to imaging, there are no sex-specific recommendations. So I want to make sure that everybody remembers to screen your women patients, but it doesn't affect my recommendations about imaging. So the way that I want to go through this is to talk about three, and these are fictional patients, but we're going to talk about a low-risk patient, an intermediate-risk patient, and a high-risk patient, and what imaging tests may or may not be appropriate in each of those scenarios, because that's how the guidelines are written, and that's how the appropriate use criteria are written. It's based on risk. So let's imagine a 42-year-old woman who is a former smoker. She has a family history of coronary disease. She comes to see you because she's worried about that. She wants to know if she should get some additional testing done. Her BMI is high at 33. Blood pressure is okay on a couple of medicines. Doesn't exercise. Doesn't pay attention to her diet. LDL 115, total cholesterol 180. And that gives her an ASCVD risk of about 3.6% at 10 years, which makes her low cardiovascular risk. So if we look at the guideline recommendations for what sorts of imaging should be done in this scenario, you will see a bunch of 2s, a bunch of 3s, which are don't do or you may consider doing, level of evidence B and C, but there are only 2 class 1 recommendations in low-risk patients, which are calculate their risk, and take a family history. So those are the only two things that are class 1. This then is a table from the appropriate use criteria, specifically looking at this clinical scenario. Patient comes to see you, they have low heart disease risk, they are asymptomatic. In that clinical scenario, no imaging or cardiovascular testing is rated as appropriate. None is rated as may be appropriate. And so everything here is coded red because it's all considered rarely appropriate. And the reason for that is there's just not any good evidence that within this patient population you substantially improve their care with imaging. So for this particular patient, I would recommend that we focus on her risk factors. We work on getting her to exercise. We try and encourage some dietary changes. She does have a history of hypertension, so if you wanted to do an electrocardiogram to screen for LVH, that would be reasonable. And if it was abnormal, doing an echo would also be reasonable. The only thing that I'm going to throw in here that we'll talk more about the evidence for later is calcium scoring. It's rated as rarely appropriate in this population, but for an individual person, it may or may not be useful. So case number 2 is a 56-year-old man, lifelong non-smoker. He also has some hypertension that's sort of marginally controlled. His total cholesterol is 220, his LDL is 155, and his ASCVD risk, if you plug it into our calculator, is now 11.3 at 10 years. So that makes him intermediate risk. Before I jump into the guidelines, I want to do a quick recap of which cardiovascular tests are available and a little bit about how each of them performs diagnostically. So exercise treadmill testing is a very simple test, is a fast test. We've been doing it for decades. I think it's important, if you've never seen one of these or performed one yourself, is that your patients should be reminded that it's just walking. It's walking uphill, but it's not running. There are a lot of patients when you say, oh, I'm going to put you on a treadmill, and they go, oh, no, I can't possibly do that. But if you remind them of exactly what they're going to be doing, they may be more accepting. It's particularly useful because you get physiologic information in addition to an assessment for ischemia. So somebody who's short of breath, they're fatigued, you bring them to your clinic, and you order a treadmill test, and come to find out they can't walk more than 2 minutes. Those patients are deconditioned. They may or may not have ischemia, but they clearly are deconditioned, and that's important information to know. So this slide is, I just put in to illustrate for you that on a standard Bruce treadmill protocol, you start off in stage 1 walking 1.7 miles per hour. And for any of you out here who are runners or have ever been on treadmill, walking that slow is actually kind of tough. It's actually like, it's pretty slow. And stage 2 is only 2.5. So you really have to be on there for 10 plus minutes before you're even getting into what might be a jog. Stress nuclear, we're all familiar with. It's also a very readily available test, well tolerated by most patients, pretty good sensitivity, less specificity for diagnosing coronary disease. It's a physiologic test. It doesn't tell you anything about what's going on with the anatomy of the coronary arteries, which becomes relevant as I talk about some of our CT-based modalities in a minute. It is associated with radiation, about 15 millisieverts. These are the pictures that we look at if you've never seen them before. So what we do is we put the patient under a gamma camera. We've given them a radio tracer. This camera travels over them and picks up all the photons that are coming out of their myocardium. And we then reconstruct these into short axis little donuts of the heart on the top, vertical axis, horizontal long axis cuts below. And then we basically just look through these, and we're trying to find areas where the color palette indicates that there's not as much activity coming from there, and we think that that is then due to obstructive coronary disease. If you are going to perform nuclear testing and your patients can't get on a treadmill and you need to do pharmacologic testing, you've got a couple of different agents to choose from: adenosine, dipyridamole, regadenoson. They all functionally end up doing the same thing, which is to increase the endogenous levels of adenosine in order to facilitate coronary vasodilation. The one that stands out with regadenoson is that it is specific to an A2A adenosine receptor, which reduces the risk of bronchospasm and makes it the better choice in patients that have COPD. I think it's also worth noting for patients when you're going to send them for this test to go ahead and prepare them for the notion that they may not feel good when this test gets done. I think we've probably all experienced that where a patient says, I'm not doing that pharmacologic thing, and I like to die, right? I hear that all the time. And that's because about a quarter of patients have some sort of sensation, pressure, discomfort, pain in their chest with all of these agents. And it's due to the adenosine. It's not due to any induced ischemia. The pharmacologic agents are primarily indicated for somebody who cannot perform an exercise treadmill test. So if they can't get on the treadmill, they got back pain, they got hip pain, they are deconditioned, then those are going to be the primary reasons for pharmacologic testing. But it's also worth noting that some of the electrocardiographic abnormalities that are in contraindications for treadmill testing also make them suitable for pharmacologic. So patients with left bundle branch block, with resting SET wave changes, those are patients that the treadmill maybe not a good choice. Pharmacologic testing may be the better choice. There are also two different nuclear imaging modalities that are worth giving you just a brief note on. There is SPECT, which is what most of us are familiar with, and then there's PET, positron emission tomography. Both of them expose the patient to a little bit of ionizing radiation. PET is less. It's probably about a third of what SPECT is. SPECT is based on a radiotracer. Typically, we use a technetium-based radiotracer, which is important in that the half-life lasts for several hours. So you actually can combine SPECT with a treadmill test if you want to do it that way. Whereas PET, the most common radiotracer that's used is rubidium. Some places have access to ammonia-based PET. But in both cases, those have a very short half-life. So the exciting stuff that's been going on in SPECT over the last several years is that we have newer software, we have newer equipment, we have newer detectors, and all of these things are helping to make the test a more efficient test. It's not really doing much to improve the accuracy, but it is making the test either faster or lower radiation, or, depending on what lab you refer to, some combination of the both. And if you fully optimize these for minimizing radiation dose, you can really drive the dose down to under 3 millisieverts. PET, like I mentioned, has a very short half-life tracer. As a result of that, you really can only perform it with pharmacologic vasodilators. We don't have any stress protocols that we are using for stress-based PET. The advantage is that positron emission tomography differs from SPECT in what we're detecting. So SPECT, you're detecting single photons, that's what the SP stands for, that are coming off of the myocardium. They're being detected by this gamma camera. And so you're doing your best to sort of say, how far away was that, where did it come from, and you're trying to track it back to the myocardium. With PET, you're detecting two photons that are given off simultaneously by the annihilation of a positron. So a positron is in the myocardium, it touches some normal matter, it annihilates into two photons. Those two photons then go out to a detector where they are detected at the same time, and that gives you 2 points of reference to go back to the myocardium, and it improves the accuracy, it improves the image quality modestly over MPI. It is not covered very well. There are some, depending on the third-party payer you're talking to, because it's reimbursed at a higher level. PET scanners are much more expensive than SPECT scanners, and so it may or may not even be available at the institutions where you work. Okay, so if you've been taking a little snooze, here's the actual evidence. I only have a couple of decent randomized controlled trials to show you here. So this is one of them that's a highlight when it comes to this question, imaging in asymptomatic patients. DIAD study was published in JAMA back in 2009. And the concept here with the study is we're going to take patients with diabetes, presumed therefore to have high cardiovascular risk, and we are going to randomly assign them to have a screening nuke or not. These are all asymptomatic patients. So they didn't give any other specific treatment recommendations to the study investigators. They just said, do the nuke, don't do a nuke, and then treat them as you see fit. So within that study, within the patients that were screened, over 6% had greater than mild ischemia. So we're actually detecting, a non-trivial amount of ischemia in these patients. As you might expect, they have diabetes, they have high cardiovascular risk. But despite finding that ischemia, there was no difference in death or MI. So 5 years out, the rate of death or MI in this population was 2.7 versus 3%. And for that matter, the positive predictive value of a positive nuclear study was only 12%. So if you screen these patients, you find an abnormal nuke, the likelihood of them having an event is still only 12%. Almost 90% of these patients do fine despite having an abnormal nuke. Switch gears and talk a little bit about echo, stress echo, which you can either do with exercise or you can do with a pharmacologic stressor. In most cases, that's dobutamine. Stress echo tends to be a little bit more specific, a little bit less sensitive, particularly if you compare it to nuclear. And it's dependent a bit on the local expertise. So there are some facilities that don't do stress echo, so this may or may not be available for you. Dobutamine is important because just doing vasodilation with echo is not going to be adequate to induce wall motion abnormalities. So you have to actually give a stressor that increases cardiac output like dobutamine. The side effects are similar to that with adenosine, regadenoson, dipyridamole, palpitations, chest pain, flushing, those sorts of things. But the complications are a little bit more concerning. So dobutamine is more likely to give you an arrhythmia, particularly atrial fibrillation and potentially VTAC or VFib. So if you have patients with those conditions, dobutamine would not be my first choice as a pharmacologic agent. I want to touch briefly on carotid IntimaMedia thickness, which some of you may be familiar with and may use in your practice. The last meta-analysis that got published on this a few years ago in JAMA demonstrated that the risk reclassification with carotid intima testing was really not very good, and that 90% of patients that had this had no change in their risk calculation. And so for that reason, plus the fact that the test is not well standardized, it's difficult to reproduce, and so it's not recommended by the guidelines that I'm going to show you in just a moment here. Cardiovascular CT angiography is another test that has grown a lot in popularity over the last several years. It is a fast and easy test. It's CT-based. Because of that, it's not great for patients that are obese and for those that have high heart rates, because part of what we're going to be doing with this test is gating the study, and we're only going to be looking at data during diastole when the heart is sitting still. So you know that the heart doesn't sit still for very long, and so if you have a high heart rate and you have less diastolic time, it's harder to get good pictures. The value of this test over the other tests that I've been talking about is that it's an anatomical test that shows you the plaque. It shows you the coronary arteries and how much they are stenosed. That makes it unique because it's the only test that detects non-obstructive plaque. So you directly see these non-obstructive lesions. It does require contrast. It does come with some radiation. Again, depending on your protocols, it's going to be somewhere in the same range as stress nuclear. Incredibly high negative predictive value. So if you do this test and you see no coronary disease, greater than 95% chance that they don't have coronary disease because you're looking directly at the coronaries. The downside is the low positive predictive value. So you do these tests, you see a stenosis, it's a little hard to be sure exactly how stenotic it is, and so we end up sending people to the cath lab that don't have obstructive disease. Here's a picture of what these tests look like when we perform them. So the panel on the left there is a 3D reconstruction of the heart. And this is fully manipulable with the mouse, so I'm just in the lab and I'm moving this around. I can see the course of the arteries. Around that 3D model, you see a stack of cross-sectional images. So those are the coronary artery cut cross-sectionally, so I can see the lumen and just how much is being encroached by the plaque. Then over on the right-hand side, what you see is what we call a multiplanar reconstruction. So this is the vessel where we've tried to sort of stretch it out and look at it in its entire length. And again, I can sort of roll this around, move it back and forth, go up and down on it. And what it shows me is where the plaque is and how stenotic it is. I think everybody can see that there are some bright white spots there in what is the distal left main and the proximal LAD, and that's all coronary plaque. So we're able to see it very easily. The question just becomes how bad is the stenosis? So that's the challenge in reading these. All right. So here's randomized trial number 2. This is the cousin of the DIAD trial. This is the Factor 64 study, which looked at 64-slice CT, again in diabetic asymptomatic patients. This was in JAMA just a couple of years ago, and these diabetic patients were randomized to have CT or no CT. And the primary outcome, again, was mortality or MI. In this case, they also had unstable angina. And as with the DIAD study, after several years of follow-up, no difference in the primary outcome, 6.2 versus 7.6. The difference with the cardiac CT was that patients who underwent that test had greater statin use and lower LDLs. Because again, you could see the plaque, you could show the plaque to the patients, it drove their change, it drove us to prescribe, it drove them to comply. But it also led to more revascularization, again, because of this low positive predictive value. So calcium scoring is another CT-based alternative that has been around for much longer than CT angiography. And the idea here, again, is that we're looking for coronary plaque. In this case, we've taken a non-contrasted CT of the chest, and we have taken anything over a certain density and colored it pink, blue, red, whatever the software chooses, and decided that that is going to be calcium. We're going to call that plaque. So you can see in this one screenshot here, the spine, the ribs, the sternum, all colored pink because they are highly calcified. But you can also see in the LAD and in the circumflex small areas of plaque where we can then take a look at this entire stack through the chest. We can see how many pixels there are that are calcified. We calculate a score, and we use that for risk stratification. And it turns out that calcium scoring really has an excellent long-term track record for risk stratification. So this is from Matt Budoff's group out on the West Coast, looked at tens of thousands of patients that had calcium scoring, followed them for 12 years. And you can see here the risk of the survival is dramatically different based on what your calcium score was. So if your calcium score was 0, your survival was greater than 99% at 12 years. If your calcium score was over 1,000, all-cause survival, 87.8%. So a pretty substantial difference in risk based on your calcium score. Calcium scoring also does a good job of risk refinement. So you take patients, you've calculated their Framingham risk, you've calculated their ASCVD risk, and they fall into low, they fall into intermediate, they fall into high. Then you perform a calcium score, and those that have high calcium scores have higher risk even within the risk classification that you already had. So you take somebody who's got low risk, they get a calcium score done, it's markedly elevated, they were low risk, but now you need to treat them as if they're intermediate or high risk. This is a meta-analysis that came out just last month in JACC Imaging and looked at 6 different studies to see whether or not calcium scoring drove changes in risk factors. So they found 11,000 some odd subjects, and they said, we're going to divide this pretty pretty easily. Either your calcium score was 0 or it was not 0. And just using that simple dichotomy with a follow-up of somewhere between 2 and 6 years, they showed that patients that had a non-zero calcium score were more likely to be on an aspirin, more likely to be on lipid-lowering therapy, more likely to be on blood pressure-lowering therapy, more likely to be continuing to take their lipid therapy, and get this, more likely to exercise, and more likely to have positive dietary changes. Now, what do you have out there? What tests do you have that actually encourages people to exercise and diet? Right? So I think that's a substantial point to think about with calcium scoring. So that's the evidence base. Those are the test options we have available. So I'm going to give you a few slides here that summarize the guidelines on this. But again, we've got a lot of class 3 recommendations here. So stress nuclear is not recommended in asymptomatic adults that are lower intermediate risk. Stress echo is not recommended. Carotid IntimaMedia thickness had a 2A in this recommendation, in this set of guidelines, but that actually was before this other meta-analysis I showed you came out. So I think it's probably not going to stand up the next time it comes around. Calcium scoring has a 2A recommendation now for intermediate risks. So that's one of the better, stronger recommendations within the guidelines. CCTA is not recommended. MRI of plaque is not recommended. These are one shot from the European guidelines, which again you'll see a lot of 2B recommendations there, and they actually give carotid ultrasound a level 3, a class 3 do not do recommendation. This is a specific subset of the guidelines that was looking at the value of secondary testing and risk stratification, and gave calcium scoring a 2B level of evidence B recommendation, so you could consider doing it. All right, so if I take all of those guidelines and smash them up into one little slide here, this is what the appropriate use criteria tell us about patients that are asymptomatic with intermediate cardiovascular risk. They break this down into can you exercise or not, because that does sort of change some of the potential recommendations. You'll see that we at least have some yellows here. We don't have any greens yet. But in patients that are at intermediate risk and they can exercise, the two things rated as may be appropriate are an exercise treadmill and calcium scoring. If they can't exercise, stress nuclear, stress echo now get up into the yellow category. But I think I've shown you evidence that the stress nuclear, at least on a population level, didn't improve outcomes. So if it's relevant to an individual patient, it may be appropriate. That's what that means, may be appropriate. But on a population level, it didn't. It hasn't been shown to improve outcomes. So for this fictional intermediate cardiovascular risk patient who has 11.3% risk at 10 years, I would recommend if he wants to have something done, if we talk about it, that calcium scoring would be the thing to do. And then let's just say, for sake of argument, that his score is somewhere in the 400s, and he says, oh, wow. Then you show him the pictures, like, look at all that calcium in your coronaries. And all of a sudden, he wants to exercise now. You tell him to put a statin on board, and then he says, I don't know, I read something about those things. I don't think I want to take those just yet. So he doesn't want to do that, but he starts taking an aspirin. He starts exercising. So you potentially made some substantial change for this patient. Okay, so let us move on then to the high cardiovascular risk population. So this is now a 62-year-old man. He's a smoker. He's got diabetes. His BMI is 34. His total cholesterol is 196. LDL is 132, despite being on atorvastatin at 40. He has got an ASCVD risk of 33% at 10 years. High cardiovascular risk. So what should we do in terms of testing for these patients? Well, nuclear now gets a 2B recommendation within the guidelines. You'll note that this is level of evidence C, and I think this is, again, one of those, in individual patients, if you think it's really going to make a difference, you could consider doing it, but there's not a good evidence base for it. In the appropriate use criteria, we now have our first green, our only green, in asymptomatic patients, and that's if they're at high risk, they can exercise, and you want to put them on a treadmill, it would be appropriate to do so. Now, if you think about how these things are created, and I just sort of gave you the briefest of snapshots of what's, how we put these together, but basically what it comes down to is exercise treadmill testing is not a real high-risk test, right? You're just having somebody walk, you're not irradiating them, you're not giving them contrast. So, the downsides are not much. The upsides are, well, if you find something, then you find something. So in that sort of balance, it then becomes, in the minds of the raters, it was an appropriate thing to do. You'll note that everything else gets a maybe, but I will just point you back to dyad, factor 64, population level, no difference in outcomes for those two groups. Calcium scoring, I've shown you some substantial sort of corroboratory evidence. I haven't shown you a big outcome trial because there isn't a big outcome trial. There are a couple of randomized trials showing, again, reductions in risk factors. But within these tests, that's the one that to me stands out as the most useful and easy to get done. So this person, he's got high cardiovascular risk. So yeah, you could consider doing a nuke, or you could consider doing a cardiovascular CT angiogram on him. But he's already at high risk. How much more risk do you want? If you find ischemia, if you find obstructive coronary disease, refer back to the COURAGE trial that showed that stenting that patient doesn't save his life and doesn't prevent MIs. So to me, the thing that would be more valuable to focus on would be his risk factors, the things that are modifiable. Could you get him to quit smoking? If you could, you have a 9% absolute risk reduction for him based on the ASCVD risk calculator. You could intensify his statin therapy. You could put him on a more potent statin. The Improve It trial, which I haven't included for you here, but I think you probably have heard of at some point, added ezetimibe to statin therapy and showed a further reduction in risk. So you could add some secondary lipid therapy potentially for this guy. So in summary of the evidence then, in general, cardiac stress imaging has not been demonstrated to be beneficial for screening in asymptomatic patients. I made a comment here about comparative data between the modalities, but basically there is none. We barely have any just looking at single modalities. And so for me to tell you this modality is better than this modality for a given patient, I really can't do that. And for that matter, I've given you some numbers about sensitivity and specificity of these tests, but those were all based on symptomatic populations, not asymptomatic populations. So presumably the test performance characteristics would be even worse in a lower pretest likelihood group of patients that are asymptomatic. My take-home points then are these. So everybody should have their cardiovascular risk calculated using some validated calculator. That can be Framingham, that can be SCORE, that can be ASCVD risk, which is the one that I use. If you don't already have it on your phone, it's a smartphone app, and it's very easy to use. Once you've done that, patients that are at low risk, and everybody, needs to have their lifestyle issues addressed. So better diet, more exercise, so on and so forth. Intermediate risk patients, you may consider some additional medical therapy. And certainly for the high-risk patients, you really want to be aggressive about those things. If you want to perform an imaging test, the one that I would recommend considering is calcium scoring. But you want to do it for patients that you think it's going to make a difference. If you don't think that they are going to be motivated by the results, if you don't think it's going to have any substantial difference in risk refinement, then you don't do the test. In patients that are going to have some stress testing done, so if you come to the end of this discussion with your patient and you decide, I think I really want to do something, you still should try and do treadmill testing first and save pharmacologic testing for those who cannot get on the treadmill. And so in general, I would avoid stress testing and CCTA in asymptomatic patients.